Hey guys, so I'm gonna give you a quick instruction on how to properly use different parts of an NG tube and actually how to insert an NG tube. I know that a lot of you are scared to put in NG tubes. Maybe you've done one or two during nursing school. Some of you might have been doing it, for years, and now you're working in a unit maybe where you don't have that many. So we'll do a little refresher on that, and then we'll talk about the different pieces that you're going to use. This is a regular Salem sump tube, NG tube, and basically any tube that has this little extra part right here is a Salem sump tube. We have two different kinds. We have this vinyl one that's a little bit tougher, and then we have a silicone one that's a little bit softer. The silicone one's a little bit harder to insert because it gets kind of caught in the esophagus. So this one's a little bit easier. To put it in, you're gonna need the tube, you're gonna need your suction tubing, you're going to need an anti-reflux valve. This is what we're gonna talk about in a minute, very important. And you're gonna need a canister and your suction regulator and some lubricating gel. So I like to start, first of all, you see this tube is very straight right here. You have to make a really significant curve once you go into the patient, and it's really hard to make that curve if you don't put a little curve right here at the end of this. So this is just a trick that I learned a long time ago. I just tie it really tight and pull, and just hold that down for a good 10 seconds. You can also run into some warm water, and it holds that shape a little bit better also. And now you see that you're gonna have a little bit of a curve there at the end. You do that right before you go put it in the patient. And then you're gonna lubricate it. Now to measure, of course, nursing school basics, you're gonna go past the solar plexus right here, just a little bit past it, and then measure to the ear. And then from there, measure to the tip of the nose, and that's how far you're gonna go. You can mark it with a little tape, you can, with a Sharpie, whatever you want. I just kind of hold it in that place and count how many parts are gonna be, how many of these sticks are gonna be sticking out. So on this patient, or me, it would be 2 of these. So I know kind of a overall general direction. All right, so now I make that little curve. The number one mistake that I see happening with people that are having trouble getting NG tubes is that they're going up in this direction. Remember, you're putting the NG tube into the stomach, not into the brain. So you want to go perpendicular to the face every time. Never like this. That's gonna cause trauma in that nose. You're gonna go perpendicular to the face in that direction. Now, what I like to do is I like to prep the patients by telling them each step that I'm going to do before I start the procedure, and then do the procedure in the same steps that I just explained to them. So I tell them, hey, I'm gonna put this tube down. It's not gonna be comfortable, but I'm gonna walk you through it, try to keep them very calm. I don't give them any water or anything to drink, but I do tell them they have to swallow at some point. They're swallowing the tube. That's literally what they're gonna be doing. And so this is on the patients that are alert conscious, of course. And so I tell them, first I'm gonna put it in your nose and I'm gonna stop. Then I'm gonna go to the back of your throat and I'm gonna stop. Then I'm gonna ask you to swallow. So those are the 3 steps. And when I do that, I also tell them that I'm gonna put my hand in the back of their head and put the neck forward. And the reason you do that is because it semi-occludes the airway a little bit so that you have a better chance of going down the esophagus and not the airway. All right, so now we start the procedure. I tell them, okay, sir, we're gonna put it in the nose. Now leave it there until they start sneezing and they kind of get over that initial tickling in that nose. Then you tell them, I'm gonna go to the next parts in the back of your throat, and you put it back there. At this point, they should not be gagging yet. Usually it's on the next part, but if you tell them to swallow, most of the time they will not gag. They're just gonna swallow that tube. Tell them it's gonna feel somewhat uncomfortable, and then you put your hand in the back of their head, you put it down to their chest, and you start going down every time that they swallow. So you tell them, okay, go ahead and swallow. They swallow, you go in a little bit, and just stop for a second. Tell them to swallow again, go in a little more. If you just kind of try to go all in, you have more of a chance of it curling. So if they can swallow 3 times, you should be in there. Once you get to the spot that you want to be, if you get stomach contents out, you're good, right? If you don't, then just ask the patient to say something. Most of the time, if you're in the airway, they're going to be coughing and gagging. But sometimes, especially in a patient that has had a stroke or isn't very alert, it might be in the airway, you might not even know it. So ask the patient to talk if they can. if they can talk, it's not in the airway, right? And most of the time, if they're comfortable, it's not gonna be in that airway. So if you have stomach contents, this tube is verified. As long as you're not giving anything through it, you don't need to do anything else. But if you plan on giving any medications through it or feeds, you have to confirm it by x-ray. All right, now, before I even start, I like to set up everything that I'm gonna use. So go back a little bit. This suction tubing, this little plastic piece, just throw it away. It's not good for anything. I like to grab these little Christmas tree looking ones because these do not come out. And you're gonna put one there. And then I don't like to connect it to suction until I'm ready or until it's in. You can, but you know, you might run into trouble with it, kind of getting hung up on things. So then this little piece right here that comes with the tube, I like to take that piece and throw it away because this is the only one that really doesn't come off. You'll find that the other ones just come off like half the time. So the other thing you want to do before you put it in, and we'll focus on this little piece right here. This is called an anti-reflux valve. And what it does, if you use it correctly, is it prevents stomach contents from coming out of this tube and spilling on the patient. It also allows for air to go in through here, right? So that this tube can keep sucking a little tiny bit of air at a time, and then it comes right back out of the NG tube and it keeps it from getting clogged up. It does the same if this is not there, but when you put this here, you allow the air to go in and nothing comes out. But a lot of people use this part right here. This is a plug. You cannot put that there, okay? It's the part that has the little lure lock at the end that goes on the blue part. It's blue with blue. I also see a lot of people doing that. That doesn't work. Has to be this way, blue with blue. This piece right here is for when you go to transport your patient or when the doctor says to seal it, then you can use that as a plug. That's all it is, that's a plug. It's not good for anything else. So please make sure that you are using the right port because some of the surgeons have been finding NG tubes like that or like that, and then their solution is just to throw them away, and now you have vomit all over the patient and you have to change their gown 50 times a day. So, anti-reflux valve, blue with this part here. If you get fluid or stomach contents up in here, you can put air through here. Some people will tell you that it's ruined. It is not. You can just put a 10 ml syringe full of air and just put it on there and you'll see the air come right back out through the NG tube to this part. As far as hooking it up to suction, you're gonna put it on whatever is ordered. Sometimes it's continuous, but most of the time it's gonna be on intermittent. I like to put it on continuous first to see where it is. Anywhere on the green is fine for low intermittent suction. And you'll hardly ever see anything other than low intermittent suction. Now when you put it on intermittent, you're gonna know even if it's out of the cycle. So you don't have to wait for it to cycle to know if it's the right suction. And then of course on your container, it goes up here in this blue container, and make sure that everything is sealed, and you test it out and you should feel sucking in, and it does. And that's pretty much it. So just to circle back, remember to use this the correct way. Remember to use these, and if you don't have these on your units, just mention it to your manager. They should be on all your parts in the POU room, and it really will save you a lot of time, you know, having to clean up your patient if it's connected with these there. And if you have any questions, you can post them in the comments zone on this Facebook feed, or you know, you can text me if you have my number, or just ask your manager.